Hi, good evening. Thank you for joining our faculty webinar on a lovely Monday afternoon. I'm still in weekend mode. It's nice to see 50 plus people in this webinar. I'm sure there will be more people joining. Today, we're going to have 3 speakers talking about functional illness in older adults and impact of COVID. So we've got some excellent topics. First by Dr. Suhana Ahmed, and then by Kapila Sachdev, and then Josie Jenkinson. And what we will do is we will go one speaker after another, and we'll have time towards the end of the 3 presentations for questions. In the meantime, if you have any questions or comments, please use the comment function to put your questions. We'll try to collate and see whether we can be interactive towards the end if time permits. And hope you will benefit from this discussion, and hope you're all feeling good, staying safe, and looking after yourselves and your family. And let me hand over the video to Dr. Suhana Ahmed. Welcome, Suhana.
Thank you, Krish, and thank you to the faculty for asking me to speak today. Thank you everyone for joining us, especially those that are on your days off. I am going to spend a little bit of time today talking about case presentations that I've seen on the ward that I work on. I'm Suhana Ahmed. I'm a consultant old age psychiatrist in the southwest of London, working on an acute inpatient old age ward. Next slide, please. So just a little bit of background to start with. I'm dual trained, so I'm adult and old age. I work 6 PAs on the old age inpatient ward. I do 2 PAs with an adult recovery support team at the moment, and I do 1 PA with Higher Education England. The ward falls under our service line of cognition, mental health and ageing. It's a 16-bedded ward and it's mixed, so we have males and females, but we also have organic and functional, so dementia and also things like depression, psychosis and so on. Our age cutoff is 75 and over, but we do occasionally accept people that are younger, that are frail, or people that are borderline. Our patients tend to come via CMHTs generally from homes, care homes, but also via liaison in the acute hospital. And most of our patients are either under the Mental Health Act or under DOLS. We have the odd few that may be informal. And we were hit quite badly by COVID sort of February, March time. And so we had to revert to an isolation wing and we had a number of cases on the ward. Next slide, please. So I'm going to talk to you in detail about 2 cases today. The first one I've named Mrs. X, and she's an 81-year-old. She had no previous contact with mental health services before, and she was admitted in May this year on Section 2 of the Mental Health Act. She was admitted by liaison psychiatry, who saw her. She was on an acute medical ward, and her husband had called the London ambulance service because he'd been worried about her not eating and drinking and her BMs being very erratic because she's diabetic. She was treated for an infection and given IV fluids while on the ward, and her history of presenting complaint was actually quite short. Before she was seen there, she had a history of about 4 to 6 weeks, about 2-week history of anxiety and becoming really preoccupied with not being able to access food during the lockdown. So she would watch the TV incessantly, she would check the food cupboards, she would talk a lot about not being able to get food if they went out to the shops. She was seen remotely by her GP, who started her on citalopram, but soon after those initial 2 weeks, she started to stop eating and drinking, staying in bed, not communicating, and became increasingly confused. And it was only really when her blood sugars became quite erratic because she wasn't eating and drinking that her husband called the ambulance service. Next slide, please. So on admission, I've literally just used verbatim here. She was really frightened. She was psychotic, and there was lots of nihilistic delusions. So she talked about having hurt thousands of people, talked about herself in quite derogatory nature, having done some very bad things, but also some very strange hallucinations about being smelly, not being able to take her clothes off. Really sort of bizarre. And the impression from the doctor admitting was that we had an 80-year-old woman admitted from an acute hospital with a likely severe depressive episode with psychotic features and reduced oral intake. And I think what was quite striking was, even when we met her husband for the first time, he wondered if his wife would have been okay if there'd been no pandemic. And he thought that what had exacerbated her decline had been not being able to go out, because they were used to going out daily. Next slide, please. Interestingly, there was initial improvement. I swapped her sertraline, her citalopram to sertraline, and she improved in the first few weeks, and then things nosedived. So she became increasingly psychotic, so really paranoid about staff. Looks like she was responding to visual hallucinations, although she would never tell us what they were. Increasingly scared and really uncommunicative, so would say very little to us. So in terms of challenges, it was her lack of engagement. So I remember having 1 or 2 reviews with her where we just sat in a room and I asked her questions and she said nothing. The second review, she sat with her eyes closed the whole time and looked quite distressed towards the end, but I wasn't able to get anything out of her. She had very minimal food and fluid intake, so we had to keep a really close eye on her BMs, and they were unstable. She needed lots and lots of encouragement to take her meds, and she regularly refused them. She also got a couple of bouts of delirium while she was on the ward, and actually she was a bit more communicative when she got the delirium. And while she was on the ward, unfortunately, we think she had a vascular event, but I'll go on to that a little bit later. And she was obviously detained on a Section 3. Next slide, please. So in terms of treatment, she came in on citalopram. We changed her to sertraline. We then added the risperidone when we realised she was very psychotic. And we went up and it had really little response, and it was quite obvious she was suffering from EPSEs. So I then decided to change to a small dose of olanzapine. But even on 5 milligrams, she had significant side effects. So she was having falls, she was really stiff. It was really difficult for her to manage. So it was at that point I changed to quetiapine. And it was around this time that I started to think about whether this woman would need ECT, because I felt like we were running out of options and she was gradually getting worse. It was just after, I think, where she had quite a serious fall on the ward and was transferred to the acute hospital, who found that she had a frontal parietal stroke. And they weren't clear if this had been a stroke that had been missed when she had been admitted. And they talked about it maybe being an emerging picture. When she returned, given the fact that she had likely had a vascular event and she was clearly suffering side effects from the antipsychotic, I decided that we would go with aripiprazole. So I changed the quetiapine to aripiprazole, and I added some mirtazapine also to her medications. Next slide, please. So probably 2 months ago, maybe just over, we sort of looked at things, and this is where I've taken this from. Her psychosis improved on the aripiprazole, and she generally was brighter. She still lacked expression, she lacked motivation, she was unwilling to engage in certain things, so was adamant that she wouldn't do a stare assessment with the physio and the OT, was adamant at times that she wouldn't come into a ward review, and we didn't know why. And she talked about still being anxious, but couldn't tell me why she was anxious. And her communication was limited, but we realised that her hearing may not be so good and had probably declined over her hospital admission. But what was clear is there'd been a step down from her baseline. And I think at that point, I realised her presentation was very different to what it had been before. She appeared sort of more flat, and it didn't feel depressive. It felt apathetic. She lacked motivation, and so what we do sometimes is get a neuroradiology review, and they looked at her scans and told us that they felt there was lots and lots of vascular damage on there. She had probably had a number of infarcts in the last year, lots of small vessel disease, and it was likely lots of vascular pathology. About 3 weeks ago, we decided that we would try her with some leave with her husband. And she went initially for a few days, and then she had some nights at home. And when she had her first lot of leave, her husband described it as going exceptionally well. And what was really nice is when we asked her how it went for her, she said she enjoyed being at home and it felt like a dream. We discharged her last week. It's probably one of the nicest moments, and I actually got quite teary about it. So as far as I know, things are going okay at the moment. Next slide. The second case is Mr. Y, who's a 77-year-old. Again, no previous contact with mental health services. Was admitted around the same time as the last lady, and Section 2 of the Mental Health Act. And he was admitted via liaison psychiatry after taking an overdose. So he had taken a planned overdose of mirtazapine, was diagnosed with tinnitus late last year, and had since February had been really struggling with the tinnitus. And there'd been a significant decline in lockdown, so he had become increasingly preoccupied with his tinnitus, felt it was he couldn't go on anymore, was very anxious and low. His wife said she could hear him walking around at night, so he wasn't sleeping, and lost a good few stones over the space of the start of lockdown. Next slide, please. So on admission, he was incredibly preoccupied with his tinnitus. It was all that he would talk about. He felt it was unbearable. He felt he couldn't live with it. It was there all the time. He found it difficult to communicate with people. He was really hopeless and resigned, and he still had suicidal ideation. So he was very clear that if the tinnitus didn't go away, he would end his life. And really agitated and anxious. And his wife described that they had lived in silence for the 6 weeks prior to overdose in lockdown, because he just would not allow her to have the TV, the radio, anything on in the house. And she said lockdown made things unbearable, and the anxiety and the preoccupation with tinnitus got much, much worse. Next slide, please. So progress, very much like the last lady, there was an initial improvement in his anxiety, and again then there was a significant decline, and around this time he was put on a Section 3. He became increasingly psychotic and developed lots of delusions about his hearing, so felt that someone had turned his hearing aid up very, very loud and he'd lost hearing in one ear. Really agitated, pacing the ward, very anxious, and some really unusual and odd behaviour. Things like throwing things over the fence in the garden and then trying to climb over the fence to be able to get those things. And then he stopped eating and drinking, wouldn't leave his bed, and refused to take medication. And I can count on one hand the amount of people that we've restrained and given IM. He needed IM aripiprazole, I think, on 3 occasions. Next slide, please. So in terms of treatment, he came in on mirtazapine. I changed him to sertraline. We tried olanzapine, but he just got worse on it in terms of psychosis, and there were some falls. And then, given his really, really good response to aripiprazole, I decided to go with oral aripiprazole, and actually his psychosis improved. He was left with low mood, so I changed his sertraline to venlafaxine, and on more than one occasion in this man's case, I thought we were heading towards ECT. And psychology was something that I had thought he would engage in at the start, but obviously he deteriorated on the ward, and so we never really got there. Next slide, please. So finally, a few months ago, there was no evidence of psychosis, no suicidal ideation or plans. There was some anxiety around his hearing still, but that only became apparent when you started to talk to him about it. He was brighter in mood and was communicating better, and he agreed to engage in psychology, which felt like a big step. But he'd clearly had a step down, and his wife said, I can't imagine him ever doing things that he would do before he came into hospital. He had some home leave, which wife was very anxious about, and then very unfortunately he had a fall at home and fractured his neck of femur, so he was transferred from us to a rehab hospital and discharged into their care. Next slide, please. So what I've done is very quickly, because of time, I have just run through some other cases, and these are literally just a few of many. There was Mrs. R, who was a 75-year-old lady, no previous history of mental health, came in having taken a planned overdose, which completely threw her family because it was so out of character for her. came in with very depressive symptoms and anxiety. While on the ward, she became quite preoccupied with cleanliness and worrying about COVID and those sorts of things. Mrs. B is a 78-year-old lady, again, no previous history, but quite strong pre-morbid personality traits of anxiety and and sort of OCD-like traits. But was functioning fine, again, until lockdown. Things broke down, so she became severely depressed with psychotic symptoms, preoccupied with cleanliness, was manually evacuating herself to try and be clean. She's still on the ward. It's probably now month 4 or 5, and she's had numerous medication changes. And Mrs. K is a 76-year-old lady with known bipolar disorder, was very compliant in her care home with meds, and came into us high, and we could find no other reason apart from lockdown, because a lot of her sort of pleasure was got from going out into places. Next slide, please. So I guess what I wanted to do was just reflect on these as we approach the end. We've definitely, without a doubt, seen an increase in the frequency and severity of functional illness on the ward. Previously, I would say we had sort of a 70-30 split, with the majority being organic. We've seen that flipped on its head. So we have seen a lot more functional people than we would have seen 8 months ago. And these people have come in very, very unwell. A large proportion of them have been first presentations with no previous contact with mental health, and all of them have tried to have some attempt to see a GP, even if it's remotely, and most of them were remotely. A proportion of them have pre-morbid personality traits such as anxiety, but not all of them. They have been really difficult to treat. There's been sort of initial improvement, which I wonder if that's because they have come out of the sort of situation and surrounding that they were in before with lockdown and come into a new environment, but they declined very quickly. I've got a typo here, that's meant to say multiple medication changes. They've needed much longer periods of admission than we would previously have thought would be needed for functional people, and on discharge they've not been back to baseline. And without a doubt, and I was talking to the other consultant on the other ward, old age ward, and he said in all of the cases that we've seen, lockdown has inevitably been a contributing factor. Next slide, please. So this slide is about my reflections. So I guess what this has shown me is a few things. How strange first impressions are. You know, when I met a lot of these patients, they came across as very straightforward cases, in inverted commas, and ones that I, you know, didn't think were that severe. I would never have guessed that some of these people would be on the ward for 6 months. I guess managing my sense of hopelessness. So I remember going into ward round sort of midway through, you know, the First Lady's stay, and just praying that someone would tell me that she'd improved, and just found myself doubting myself. And I guess putting myself under lots of pressure to make changes and do things quickly, because I felt like I needed to get her better somehow. Realistic hope. So I think a lot of what I did in that period, and what my trainees did, was giving families a message of hope. You know, when your loved one has been in for 4 months and they haven't improved, we had lots of regular meetings with family members, and we talked very much about the diagnosis and the fact that there was more scope for treatment. And I think what this has made me realise is sort of how broad recovery is. I think what we did on the ward was we helped them recover in terms of the first step, and you know, we helped them with their acute illness. But I think recovery is a much longer process. So like with the first woman, she was incredibly anxious about going back home after being in hospital for 6 months. So the second part of her recovery was reintegrating back into normal life and going back to some of the anxieties that were there when she came into hospital. So that's all I had to say. Next slide, please. I think we're going to do questions at the end, but my contact details are there if anyone has anything that they want to contact me about. And I'm now going to hand over to Kapila. Thanks, Kapila.
Thank you. That was a wonderful presentation. That matches up some of my kind of things. So Yeah, so my name's Kapila Sachdev. I am an old age psychiatrist. I work in the community setting in East London Foundation Trust. Just checking, you can hear me because my computer says, yeah, okay. So my name's Kapila Sachdev. I'm one of the old age psychiatrists. I work in the community in East London Foundation Trust in Tower Hamlets Borough. And today I'm going to talk about a summary of recent research findings on impact of COVID-19 on older people's mental health. I will concentrate on the functional illnesses, but of course there's been a mixture of presentations. Next slide, please. So the outline of my presentation would be what was the reason for looking at this research? I'll kind of give details of the list of papers that I looked at. It is an evolving subject, and every single day you see something new coming through, and so screening all of it has been hard work. I'll talk about 4 papers in detail with some of the key recommendations that the papers made. And then there is a table that I will give at the end, which will talk about literature for maintaining mental health in older people during the COVID-19 quarantine. There are WHO recommendations on it as well. And a brief outline on suicide in England since the pandemic. Next slide, please. So why did I look at these papers? So at the beginning of the pandemic, and as we went through the pandemic, starting from March to about August, my colleague and I noticed in our CMHT there was an increase in the number of referrals. We still continue to have an increased number which we received, which was very much unlike, we have had more dementia referrals, but this was more people presenting with anxiety, with depression, with psychotic symptoms. Inability to sleep was the top one. Carers were feeling quite burdened, paranoia, and a lot of increase in disturbed behavior. And we wondered why was there an increase? Of course, there was the pandemic. Of course, there were a lot of people who were locked down, but never been in pandemic. So here I was looking at it. Looked at some of the researchers where the SARS epidemic in 2003 in Hong Kong was associated with 30% increase in suicide of those 65 years and older, which was kind of a very stark reminder of what an epidemic or a pandemic or the fear of it can do to our individuals. There was some research by Yip et al. Who actually analyzed about 22 suicides, and the average age of these suicides was about 74.9 years. So, and out of which 12 were afraid of contracting the SARS, which is kind of what we felt was happening to a large extent. And some of the research concentrated on the older people thinking of suicide as an altruistic move, more of not being a burden to their family members, which was also kind of a shocker when I read it. Out of these, 50% of patients remained anxious and 29% of healthcare workers continued to be anxious. So it has very big implications for our healthcare system. Next slide, please. So first thing about when you start looking for all of these research papers, they come up with, there's been a lot of predictive modeling which has been going on. The most recent one was the mental health search model, which was published by the strategy unit. That described about 11% more new referrals will be made to mental health services generally for each year for the next 3 years, which kind of tells us what would be the impact on the services, which the cost of which would amount to about an extra 1 billion a year. And we have heard that we are going to get extra funding, but it is going to be an interesting time for mental health services. There is, and all of this is in addition to about 500,000 people who were unable to access services during the national lockdown. So it is amounting to huge numbers and a huge amount of impact on the mental health services. Next slide, please. So looking at the studies that were published, there have been a number of publications which came out from the Wuhan area in China, of course, who were the first ones to face this pandemic. And they talked, but some of the studies which came out a bit later, there was an ELSA sub-study on COVID-19, which I will talk about. There was a study published in Journal of Nutrition and Aging talking about impact of social isolation due to COVID-19 on health in older people, both mental and physical effects. There was a study recently published in the Progress in Neurology and Psychiatry, which talked about social isolation and its impact on mental health. There's some, Age UK has come out with some papers. And then there were a few papers which talked about psychological impact of COVID-19 in older adults, which was published in Pakistan. There was a Lancet paper about the research priorities that should be thought about, and in a Wuhan-based paper on COVID-19 on loneliness, mental health, and health service utilization, which was a prospective cohort study. Next slide, please. So I'll talk about the ELSA COVID sub-study, which ELSA stands for English Longitudinal Study of Aging. It was kind of an interesting study. So what the study was, it was an ad hoc study. It wanted to look at the experiences of older people, its effect on health, finances, and social impact of it, including volunteering. It was funded by the Economic and Social Research, and UCL was a part of it, and they kind of brought it on. So the invitations to participate were sent by email around the 3rd of June, and they invited about 9,392 individuals. The study carried on from beginning of June to end of July, and about 7,040 people agreed to be volunteer for the study. 82% were carried out over the internet and 18% over the telephone. So they used various measures. So mainly on mental health, they used the GAD-7 study, GAD-7 for anxiety, CSD for depression, and well-being through ONS. And they plan to do a repeat assessment in November, so it might be going on at this point of time. So the main findings, which I kind of wanted to bring to this group, were about 60% of older people who were instructed to shield were actually strictly isolating in April and May. So about 40% of them were not. And among those people who were instructed to shield and were actually shielding, there was evidence of severe depression and anxiety symptoms, which was twice as common among this group who was socially isolating compared to an average risk participant. So they came up with figures of 32% versus 17%. As we would know, once you are socially isolated, you'll end up being quite lonely. Loneliness was much more common. And many of these participants in the high-risk group were more likely to be hospitalized. So they had about 15% more admissions to hospital due to COVID-19 versus 3%. And there was, as we heard in the first case, which Suhana presented, there was worry about obtaining food and other essentials by this group. So a lot of impact in all of the aspects which could trigger anxiety and depression in this group. They were also less likely to be physically active than usual. And we know for a fact that a lot of this pandemic would result in high numbers of people who would become housebound, and the physical health impacts of it and the mental health impacts. So they were 47% less likely to be going out. 47% of them were less likely to be physically active versus the 33% of the control group. Next slide, please. And they also looked at people who had multimorbidity. So multimorbidity is defined as people with 2 or more health conditions. So about 35% of them were instructed by the NHS or GP to shield. And 94% of them were actually isolating or staying at home in April 2020. And mainly the main concern was they did not have access to community health and social care services and all the support needed. So it did have an actual impact on them accessing most of these services, which then resulted in a lot of more presentations or difficulty in managing with the lockdown. Next slide, please. The other study that I looked at was published in the Journal of Nutrition and Healthy Aging. This was on 25th of September. It looked at impact of social isolation due to COVID-19 on health in older people, both mental and physical effects. And they looked at GAD-7, and there was the main outcomes reported were anxiety, depression, poor sleep quality, and physical inactivity. And both mental and physical health were negatively impacted on older people. So it kind of highlights what has been the running theme, that people were asked to isolate, and a lot of it negatively impacted on their mental and physical health. They recommended multi-component exercise and physical health strategies, and the motivation part of it was also kind of seen as something that was lacking in this group. Next slide, please. This was recently published, so it was in 9th of November. Again, it looked at the mental health impacts of social isolation in older people during COVID-19 pandemic. This was a review of literature by Dr. Tappenden and Dr. Kumar on the mental health consequences of social isolation during epidemics. They looked at, it's a narrative review, and they looked at about community living. It was all on community living adult services. So they looked through a number of studies. Eventually, they picked up about 41 studies, which mentioned social isolation, pandemic, and epidemic as parts of it. 10 of these studies looked at the impact of social isolation, and they divided the impact on short-term effects and the long-term effects. Generally, the effects of social isolation resulted in decline in cognition, mood, sensitivity to threat, higher rates of depression and anxiety. Now, I have seen a lot of the mild cognitive impairments progressing towards the, dementia pretty quickly within the last 6 months, and the numbers have really risen. I've also seen a lot of mood elements, so this was kind of adding on weight to what we were actually seeing. The short-term effects were less well studied in older adults. So they looked at the SARS epidemic mainly, but they also talked about loneliness, abandonment, social exclusion, stress, anxiety, and depression. Interestingly, there was a study in China, and they looked at 52,730 participants in this. And they noticed about 35% of these people experienced psychological distress. And they identified 3 groups in that were most vulnerable. One was the younger age group, which was 18 to 30 years, the elderly, who were more than 60 years, and the migrant workers. What was brought to my attention today by Dr. Amanda Thomsell was there is the Spotlight report, which looked at 72,000 adults. It was a UCL survey. In UK, what they found was younger adults did much worse in their mental health, which was the 18 to 29 years of age group, as compared to the older age group. The prevalence of anxiety remained high among this group, even after the lockdown was opened. And generally what they found that the older and the middle age group did better. So this was the UK part of it. But you would expect some changes over the long term. And now in the long-term effects that this study talked about, the social isolation study in neurology and psychiatry, they talked about the older adults being more likely to lose their partners or their friend groups, and they would be experiencing more complicated bereavement reactions, higher rates of depression, higher rates of PTSD, and prolonged grief symptoms. In addition to that, this is the group which is most likely to be admitted to hospital So they are more likely to experience PTSD, anxiety, and depression post-COVID pandemic. So that's the group we will be looking after. Next slide, please. The last report that I kind of would talk about detail in is about the Age UK report. So they talked about the impact on physical health. So about 1/3 of the individuals felt less energetic. 1/5 became less steady and were unable to walk as before. About 1/4 of them were unable to walk as far as before. This shows that this is a developing problem. There was a lot about diet and malnutrition, which was related to low mood, lack of help for food prep, decreased physical health and inactivity, and increased pain. They also picked up on newer emerging cognitive decline, which kind of hastened through this pandemic. People who were asked to shield or had multiple comorbidities, 1/3 were more anxious or had developed anxiety. Proportion of over 70s who had developed depression had doubled since the start of pandemic, so a large number. And 1 in 3 over 60 feel less motivated to do things they used to enjoy. And there was a lot about self-neglect and effect of bereavement on this group. Next slide, please. So going briefly, I've given some of the recommendations from literature for maintaining mental health in older people during COVID-19 quarantine. About keeping connected to prevent loneliness, now use of digital resources. Now there was a study in Italy about this, where people who had delirium, people who had dementia, when they lost contact with their family members or were supposed to speak to them virtually, they had more episodes of delirium. There was a mention about how to prevent cognitive impairment, think of sleep-wake, keeping a normal sleep-wake cycle. This was all for the patient. For the caregivers, there's about preventing depressive symptoms, preventing anxiety, helping people continue to do their chores, doing gardening, preventing overexposure to media. And we've heard of people who started getting preoccupied with listening to the news. Next slide, please. For the health workers to consider implementing telehealth was through one study, giving care to vulnerable population, teleassessment by video, cognitive and physical stimulation. There was about anxiety and depressive symptoms, psychological training and surveillance in risk cases, and reduction of stress. Next slide, please. And health authority and dementia care, of course, which we've heard about, which we all know about, but has been very difficult for the caregivers. Increasing the resilience, but this was supposed to be by the health authorities. How do they increase resilience, gain compliance with lockdown strategies, giving short and considering inclusive language, valuing older people's contributions, and avoiding negative emphasis on risk, which I think is quite true. Reducing stress, keep quarantine as short as possible, so repeated quarantines will happen, and provide adequate supplies. Next slide, please. And lastly, talking about suicide, and these were this is a preliminary report which was produced by the National Confidential Inquiry into Suicide and Self-Harm, and this is from real-time. They use real-time surveillance because recording of suicide takes a longer period of time, and they covered a population of 9 million. So 2020 monthly average pre-lockdown was about 84, post-lockdown was 85.4. The post-lockdown figure was about 7.3% higher than equivalent period in 2019, but the conclusions were there was no evidence of national rise in suicide post-lockdown. And the higher figures in 2020 could be seen in context of rising national rate and maturing real-time surveillance studies. And they do say it is too early to examine full long-term impact of COVID-19, including the economic consequences and other consequences on health, and they are likely to change over time. Next slide, please. And these are the studies. I would like to acknowledge Dr. Amanda Thompson, our previous faculty exec president, who has helped in compiling these. Thank you. And I will move on. I'll invite Josie to speak now on the most interesting topic of another interesting topic. Thank you.
I don't think you can hear anything I'm saying because I was on mute. Sorry about that. So hi everyone. Thank you so much for coming to listen to us talk today. Thanks to Suhana and Kapila for giving such interesting presentations. So I'm Josie Jenkinson, I'm Vice Chair of the faculty and I'm a liaison psychiatrist for older people, currently working full-time at Surrey and Borders Partnership. And I'd like to round off this webinar by talking to you briefly about a project that's currently underway exploring rates of deliberate self-harm in older adults during the coronavirus pandemic by means of using liaison service referral data. Next slide, please. So I'm going to be talking about the background to this project and how it's evolved into a really great collaboration between several trusts and the rationale, and present some preliminary findings to you as well as next steps. I'd be really grateful for any ideas about how you think we could improve this project, and also keen to find further trusts to collaborate with if possible if you're interested. Okay, next slide. So where did the idea for this project come from? Well, so at Surrey and Borders, we're very fortunate to have 5 very well developed liaison psychiatry services covering both older adults and working age adults across the county, 1 for each acute hospital in Surrey. And the great thing about this is we have a very close network of consultant colleagues who speak often. Hopefully some of them are on the call today. And anecdotally, the feeling was that from the point of view of things really hotting up with the coronavirus pandemic at the beginning of the year in the UK and the start of the first lockdown, our referral rates had gone right down, but what we were seeing was what felt like much higher numbers of older people presenting with very severe deliberate self-harm. And this was also in the context of, I'm sure has happened elsewhere, of our community services for older people having to drastically reduce face-to-face contacts to protect people from infection with the rapid expansion of virtual and telephone appointments. So instinctively, we felt that stress and loneliness during the pandemic was likely going to have greater impacts on older people, and we didn't think it was unreasonable to predict this might increase rates of deliberate self-harm and suicide in older people. Another great thing about working liaison at Surrey is that we have really good quality referral data. In light of the rapid expansion of liaison services due to investment following a 5-year forward view, a lot of really robust data collection systems were put in place. So we decided to try and use that and explore what was really happening with referrals to older adults to liaison services during COVID, and whether or not presentations of older people with deliberate self-harm were actually increasing. Next slide, please. So what do we already know about this? So Kapila's given a really nice summary of more recent research, but there is some older research that makes a case for increased rates of depression and suicidality in the context of loneliness and isolation. So a retrospective study in 2014 used English hospital mortality statistics, identified that older people with a diagnosis of depression are 15 times more likely to engage in self-harm. Social isolation, living alone, have been found to be associated with increased suicidality in older adults. And loneliness has been associated with an almost threefold risk of suicide attempts and completed suicide in both men and women, with those above 75 being the most affected. Also, a meta-analysis in 2017, so across 31 studies, I think around 200,000 participants, found that loneliness and lack of social support were strong predictors of suicidal ideation. Next slide, please. Also considering COVID-19 pandemic, so older adults could be considered at increased risk of experiencing suicidal ideation because of the rules of quarantine and increased social isolation as a consequence. During the pandemic, as we've discussed, older people have been advised to keep isolated and maintain social distancing to stay safe, and this should cause us concern as older adults generally are considered higher risk than most of physical and mental health problems, and social isolation being linked with anxiety or low mood symptomatology, which we've heard about from Kapila. Also, being constantly exposed to distressing and negative content in the news related to the pandemic, lack of interaction and a minimal chance to express concerns with their loved ones also raises the possibility of increased risk of suicidality and feelings of hopelessness within our older adults. I'm thinking about the data that's already out there. So the Office for National Statistics published provisional data for the second quarter of 2020 at the peak of the COVID-19 pandemic, which showed that there were 6.9 deaths by suicide per 100,000 people in England. But this was actually the lowest of any quarter since 2001. But the ONS said that the lower number between April and June should be interpreted with caution because, to be expected, the pandemic meant that inquests were delayed because of the pandemic meant that they were delayed because of pressure on services generally. The National Confidential Inquiry into Suicide, I think Kapila mentioned as well, have published some data on suicide rates during lockdown and just afterwards, but they showed no increase in suicides since lockdown if you take into account a rising trend in suicide generally. But it's really early data and I couldn't find any demographic breakdown of that data. So during the pandemic, older people have been advised to keep isolated, maintain social distancing. It's clear to see that for many older people, lockdown could result in increased isolation and loneliness, which may have led to increased rates of depression and as such, increased rates of deliberate self-harm and suicide. Considering the strain that the pandemic might place on older people, it's quite reasonable to suggest that the rate of hospital presentations due to suicidality may increase. So we thought we should explore this to capture whether or not there is a problem, as evidence might help us in the argument for expansion of resources, services to support older people's mental health needs specific to the pandemic. So what did we do? Next slide, please. So we started to look at SABP data, see if it was good enough quality and accessible, and it was. We discussed with our local R&D department and the audit department. They were happy to register this without any ethical approval as it was routinely collected data, and put a call out over recently set up JISC mail, a mailing list for the older adult faculty to see if anybody wanted to collaborate to increase our data pool. And we got quite a lot of responses. We met virtually to discuss and expand the idea. We put together a one-page methodology and a data collection pro forma, which we shared amongst the collaborators. And then we started data collection with support of other old age liaison consultants and some very helpful junior doctors. Next slide, please. So our collaborators all really needed to have very well set up liaison services similar to SABP, as well as access to the same high quality referral data. And fantastically, we found 5 really great collaborators. So that's Birmingham, Solihull, Nottinghamshire Healthcare, Oxley's, East London, Norfolk and Suffolk. And then just in case I forget, I want to say thank you now for your support with the project and for being such great people to collaborate with, particularly the lead consultants there, who's been incredibly helpful. So that's Sarah Ormerod at Birmingham, Kahindi Junaid at Nottinghamshire, Sunita Sahu at Oxley's, Hugh Grant Peterkin, James Lee Davey and Mazen Deher at Elft, and Julian Beeshold at Norfolk and Suffolk, and Adrian Leddy at Norfolk and Suffolk. So thank you so much. It's been really lovely to have an opportunity to connect with other old age liaison consultants in particular. So following an initial meeting and discussion, we carried on with our data collection. All the collaborators had to register it with their local R&D departments and get permission to share their anonymised data with us at SABP so that we could pool it. Next slide, please. So we looked at data for a 3-month time period from the start of lockdown. So that's the 23rd of March was the day we went into lockdown to the 23rd of June. We compared it with exactly the same time period in 2019. We thought that was best because of the seasonal variation that you tend to get in liaison referrals. And we then pulled anonymised data and have just started analysing it. We've also requested data on completed suicide from trusts because trusts should collect data on suicide in people known to mental health trusts within, I think it's 6 months of the death. So we thought that would be interesting data to look at as well. So next slide, please. So here's the preliminary data. This is hot off the press. So you can see the collaborators all there. And so you've got 2019 data, 2020 data, so that's a 3-month period, as I mentioned. And you've got the total number of referrals to old age liaison and the number of referrals, people referred specifically due to deliberate self-harm, and we've also put the percentage of referral rates there. So I think what struck me is how busy liaison services are and how many referrals there are. And it was quite interesting to see similar percentage rates overall for referrals to people with deliberate self-harm. They don't vary hugely, I don't think. Next slide, please. So this is just an illustration of that data in graphic form, just looks a little bit prettier. So you can see how the data is made up by the different trusts, and you can see visually there that the number of referrals for people with deliberate self-harm haven't really gone up. However, as a proportion of the total number of referrals that we were getting to liaison, it's a greater proportion. Next slide, please. So there are a few possible reasons as to why this might be. So I think I was talking about this with somebody in the chat box. So people were getting discharged much more quickly because of release of funds. So people were not staying in the hospital very long, so perhaps not being referred to us as often. I suspect liaison services became a bit stricter about their referral criteria. I know certainly with us in our service, right at the beginning of the pandemic, when everybody was really not sure about how to manage things, we were trying to reduce face-to-face contacts and do a bit more stuff over phone. Also, I think that people with less serious problems were just generally staying away from the hospital. So just the numbers of acute presentations were generally down. We haven't answered the question as to whether presentations were more severe or if they're more completed suicides. And also, I wonder if it may have been delayed effect to all of this. So we only looked at 3 months, and anecdotally now referrals have increased back to their usual levels. So we're kind of as busy now as we would be for this time of year, if not busier in liaison. So next slide, please. So our next steps is to do a more detailed analysis of the data. We've decided that we're going to extend the data collection period to 12 months. So we're going to do from March 23rd, 2019 all the way through to 2020 and continue collecting data up to 23rd of June 2021. We would really like to expand the data set by further collaboration. So if anybody's interested, get in touch. And we're going to look for ethical approval to do more of a deep dive into individual records, so we can look at factors contributing to suicidality during the pandemic. And if we get funding for this or enough time, then we may look at doing some patient interviews to explore this further. And we're going to request the data on completed suicide for this age group from the NCISH and also via our local trusts. Next slide, please. So this is everybody that's helped with the project so far in terms of leading and data collection. So thank you all very much. I'm really grateful for your support. Next slide. Some references. I'm happy to send these out to anybody that's interested. Next slide. That's my email address. Do please get in touch. That's my Twitter handle there too. So if you're interested in collaborating or got any ideas as to how we could expand this project, make it more useful, please let me know. And we've only got about 6 minutes, so I'll be quiet now and hopefully we can have some Q&A.
Thank you. Thank you, Suhana, Josie, and Kapila. I think it has been a quite a interesting afternoon, having from case discussion, some research, and then on the deliberate self-harm, which I think is a really important topic. Across the country, we have seen definitely significant increase in suicide or deliberate self-harm. In fact, when Amanda, our previous chair, quoted a figure and people got quite upset about it, but it is a fact that in older adults, the DSH definitely has significantly gone up. So we had lots of comments and questions, and thank you, Suhana and Josie, for replying it along so that we are shortage of time. So I've got a couple of questions, and then Suhana, if I can ask about, I think you already answered on the visiting policy, and they are asking about ECT services. Do you have anything to add, please? You're on mute.
No, ECT, we were actually very lucky with our ECT services. They carried on. They obviously were a bit more stringent in terms of who they accepted, but there wasn't any major problems. And actually, I thought we would have at least 2 or 3 people that would need ECT, and they didn't need to go, so we didn't actually need to utilise it. So we were very fortunate in that case. I've tried to answer the visitors question. The policy from the trust after the first lockdown was no visitors. It was majorly problematic for various reasons. We did make very good use of our iPad, which we hadn't done before. So we did lots of sort of videos with family and so on, but nothing substitutes a family member for a patient with dementia, or even someone that's very, very unwell. So this time we have kept visitors running, but on a booking system and using PPE, and touch wood, so far it's gone okay.
Next. Yeah, and then there are lots of comments thanking all of you, and Rob says excellent, very clear presentation to all 3 presenters. So is Rashi, and she talked about the suicide project, quite an essential project. So lots of thumbs up for all of you. And there were a few other comments. I think Rohan mentioned that they probably have more PD due to vascular changes with COVID. And so again, I have not seen a specific reference, but that's something for us to think about. And there was a couple of questions on OCD, and it's quite an interesting thing. I don't have an answer. They said, how do you treat OCD, especially asking, you're asking them to wash their hands and using sanitizers. Does anybody have a comment on it at this moment in time? I suppose more obsessed you are, it's better to safeguard yourself, I suppose, on a pragmatic level, but I'm not sure how it will impact on people who are having like cleanliness as a specific obsession. Anyone? Any answer?
I could say something.
Suhana, Kitty, if you want to.
From a ward point of view, we did have lots of people like this. I think it was easier on a ward to be more boundaried. in terms of the number of times. So it's very objective about how often we would be able to keep an eye on how long people were washing their hands for. And we actually sought some psychology advice about the best way around that. Obviously, it's much harder in the community with people because you can't have that, obviously.
Thank you. Thank you. I think we are nearly there, aren't we? Yeah, so we are 1 minute to 5 o'clock. I don't want to kind of stop your Monday to extend your Monday beyond. I think it's been a really interesting afternoon. If it was a face-to-face, we would have given them on a clap, and I'm going to get a clap on the GIF at some point. But thank you, Suhana. Thank you, Josie and Kapila, and thank you to Kitty and our organizing team who have been behind the scene, getting this all seamlessly working for us. And hopefully we will try to see you with another webinar very soon. And don't forget, we have our BGS and faculty joint conference on 2nd of December. Seem to have attracted a lot of delegates. We already have over 400 subscribed. So if you have not, please subscribe and ask your colleagues to join. It seemed to be a very exciting program and look forward to seeing you on 2nd of December. And also please use the JISC mail. I think this is the time for us to work together, share ideas, and then try to improve our own individual work environment as well as the faculty. And without further ado, I would like to close the session unless anybody have anything. Yeah, it's I just want to thank Kitty, Rebecca, and Stephanie and everyone. So thank you so much and have a good evening. Thanks a lot.